So thanks very much. It really is an honor to be able to report on this study on behalf of the PR21 investigators, and want to really acknowledge Dr. Kim Chi and Dr. Francois Bernard, who really were instrumental in leading this very important randomized trial. So by way of background, we know that lutetium and PSMA has efficacy through the VISION trial, which looked at comparing it against best standard of care in sort of third-line treatment. And as we heard earlier from the patient perspective, moving an effective therapy up earlier in the trajectory of the disease is a pressing question. So this study looked to evaluate the effectiveness of lutetium PSMA when delivered sort of the next line up. So after progression after an ARPI, but before chemotherapy. So we know through studies like PSMA-4 that lutetium PSMA does have efficacy in this setting. It's better than an ARPI change. And we also have a lot of experience knowing what to expect from taxane-based chemotherapy at this stage of the cancer. And there's a KEYNOTE-921 trial, sort of contemporary trial. So there was a desire to try and examine, compare these two treatments against each other, but also sequencing. One of my medical oncology colleagues, Dr. Kylie Potvin, illustrates the challenge of this kind of a comparison. She calls the taxanes the black widow of cancer treatments because it kills whatever it's paired with. So whatever you compare against docetaxel doesn't win. So this is a high bar to compare with. So this is what the setting in which this study was undertaken. So basically, eligibility similar to VISION, or in terms of PSMA positivity and standard hematologic parameters and performance status and such, and then randomization 1-to-1 between initial lutetium PSMA versus docetaxel. So this is after first progression after ADT plus ARPI. And then, interestingly, followed with conventional imaging. So at time of radiographic progression, men could be switched over to the other therapy, followed again for second radiographic progression. And so primary endpoint was first radiographic progression. Secondary endpoints included overall survival, secondary radiographic progression, PSA decline, toxicity. So this was powered as a sort of one-sided comparison with 200 men to be randomized with the goal of 150 events before evaluating for the primary endpoint. And so the study design is there. In terms of the accrual, the 224 men screened, just 199 met the eligibility criteria, and primarily exclusion primarily on the basis of inadequate uptake PSMA PET. And then about 100 in each arm. Most men completed the assigned therapy within the PSMA, lutetium PSMA, 5 cycles median. Within the docetaxel, 8 out of a planned 12 was the median. And interestingly, among men who discontinued treatment, there was a higher proportion of men discontinuing treatment among the docetaxel arm because of toxicity, which speaks to the toxicity of chemotherapy versus lutetium and PSMA, where only one man discontinued treatment because of toxicity. And then, interestingly, there was also a imbalance between men who subsequently went on to the other therapy. So more men who got docetaxel subsequently got lutetium, versus the lutetium, fewer men went on to docetaxel. And I think this speaks to the fact, again, we heard earlier, there's this cumulative effect on men with multiple lines of therapy, and that can preclude getting to second and third lines of treatment. And that will become important in the results. So you can see that among the baseline characteristics, they were well balanced in terms of performance important prognostic factors like performance status, PSA at the time of enrollment, proportion of men with visceral involvement, and other important prognostic factors. So just well balanced between the important factors. And so when you look at the primary endpoint of radiographic progression-free survival, really no difference. So both lutetium PSMA and docetaxel providing somewhere around 9 to 10 months of progression-free survival as gauged by conventional imaging. And then when you look at a forest plot, they tried to discern, was there certain men who did better with one treatment versus the other, and really it was kind of a wash across all of the, the known important prognostic factors. Very interesting, this is probably the most interesting slide to me, is we know there's this correlation between expression as gauged by SUV from things like therapy and vision, and generally higher SUV predicts better response to lutetium PSMA. But in this study, SUV mean was prognostic, but it wasn't predictive. So what it meant was that if you had a high SUV mean, so SUV mean greater than 9, you did better with both the docetaxel and the lutetium PSMA versus a low SUV mean. So there's something telling us about the biology of the cancer, but it speaks to this we heard in the last session, the expression may not be the whole story as we measure. There's other biologic things going on that we need to take into account. In terms of secondary endpoints, so PSA 50, about a third of men with lutetium PSMA had a deep PSA response versus just over 10% with docetaxel. Time to quality of life deterioration was similar between the two. In terms of adverse events, you can just sort of gauge by the area under the curve with the various colors. The chemotherapy on the left tends to be a little higher proportion of adverse events versus the lutetium PSMA, with dry mouth being the major one on the lutetium PSMA. And there was definitely fewer grade 3 and 4 toxicities among lutetium versus the docetaxel. So again, now we have this interesting secondary endpoint of overall survival, which suggests that overall survival was better with docetaxel versus lutetium PSMA. But I think we now have to think back to the what happened next question, and the proportion of men who went on to an initial line of therapy was higher in the men who had docetaxel. So more men accessed lutetium PSMA after docetaxel versus accessing lutetium PSMA or docetaxel after lutetium PSMA. So there is a selection bias as to how many cycles of therapy the men got. And so this slide here is, hot off the press. It's being reported at ASCO next week. It's in the published abstract book, but basically shows that from the time of crossover, overall, all of the endpoints with lutetium or docetaxel were the same. So once you got to that treatment, you did equally well with lutetium or with docetaxel, but you had to get to that treatment. And overall survival, as you might expect, for those men who did not cross over to the other treatment was worse. So in conclusion, we now see, now we have two black widows fighting against each other. It's kind of a draw, I guess, because they're both effective. And I think what we are now challenged to do is to figure out the sequencing. And the sequencing is really, I think, driven by what is going to allow the man to access the most lines of therapy. Because any of these treatments are buying them time. They're not curative. And so if we want to give men the advantage of additional lines of therapy, we have to be mindful about how we, sequence, not just for, predicting for response to the therapy we're considering, but what happens next later. And so those men who may be more fit and able to have chemotherapy, maybe that is the right choice, because then they can cross over to lutetium and they'll be able to access it later. But even though lutetium is well tolerated, maybe there's just enough to tip them over the edge so that docetaxel as the next line of therapy may not be practical. All of this is very gestaltish. We don't have good biomarkers to predict for this yet. There's some interesting data around other biomarkers like P53 mutation predicting response to the different agents. But this trial will be subanalyzed for other biomarkers and things, but asking a very important question and raising lots of questions more than answers, I think. So acknowledge all the investigators and the patients who participated. Thank you.